Hi, everyone, and welcome to our Youngtimers Ask the Expert series. Today, we'll be speaking with Sinem Karipcin about reproductive options for members of the early onset familial Alzheimer's disease community interested in not passing the disease onto their children, specifically in vitro fertilization with pre-implantation genetic testing, also known as IVF with PGT. Dr. Karipcin is a fertility specialist at the Columbia University Fertility Center and assistant professor of obstetrics and gynecology at Columbia University. She is board certified in both obstetrics and gynecology and reproductive endocrinology and infertility. She is the director of the pre-pregnancy genetics program and is an expert on decreasing risk of genetically heritable diseases with ongoing research on pre-implantation genetic testing. Dr. Karipcin, thank you so much for joining us.
Thank you so much, Lindsay, for having me.
Thank you. Before we begin, I wanted to take a moment to say that at Youngtimers, we respect all reproductive options, whether that be natural pregnancy and conception, adoption, deciding not to have children, or pursuing assisted reproductive technology. It is our goal to educate the familial Alzheimer's disease community so they can make the most informed decisions about their future and care.
I'm glad you specified that because for the pre-pregnancy genetics program, our goal is to reach out to carriers of genetic diseases and inform them about their reproductive possibilities. But the reproductive possibilities are not only limited to pre-implantation genetic testing, it's just one of the options. We have a genetic counselor in our program, actually a couple of genetic counselors from Colombia that work with us. The patients not only learn about their option for PGT, but also they get to know of other options, no testing or just no children or adoption or donor egg, donor sperm. All of these are possible.
I think a genetic counselor is so important to bring into this discussion as well as a fertility specialist. Can you provide us with a general overview of the steps and timeline involved with IVF?
Absolutely. The IVF process is about a 10 to 14 day process for ovarian stimulation. It typically starts with the woman having her period. It doesn't necessarily start with a period. But what we do is give naturally occurring hormones, follicle stimulating hormone and LH hormone from outside to grow multiple follicles in the same time. During the IVF process, woman will be administering herself the shots of follicle stimulating hormone and LH hormone. These shots will be under the skin every day, and she'll come for ultrasound monitoring. Those are pelvic ultrasounds, and initially those ultrasounds will be every 3 days, then every 2 days. Close to the retrieval, it could be every day. This is going to be finalized with the egg retrieval. I am using ER, egg retrieval. After that, we are done, and everything takes place in the IVF lab. In the IVF lab, what happens is we put the eggs that are collected and we put them together with the sperm. For PGT-M cases, it's going to be injecting the sperm inside the egg, which is called ICSI. Then we are going to culture the embryos for a week in the IVF lab until they form a blastocyst, which has the inner cell mass, what makes the baby, and the placenta, which is called trophectoderm at this stage. TE, trophectoderm, makes the placenta. This makes the baby. It's actually more than 50% of the cycles in the United States include genetic testing of the embryos. And that's doing a sample of what makes the placenta, taking 5 to 8 cells, and sending that analysis for a specialty lab looking for chromosome numbers. A small proportion of those cases are also looking for a certain condition. It could be couple, could be a carrier for cystic fibrosis. We could be looking for that. That is going to be the type of PGT that we're looking for. This is overall the IVF process in a nutshell. And IVF is not always like this. It's not always embryo biopsy. It's not always culturing to day 7. It could be sometimes day 3 cultures, fresh transfers. But that's the most common type of IVF that we do.
Once you have the embryo, what is the next step for the couple to expect?
Actually, there is more to expect before the embryo. In an IVF cycle, before we start, if we are looking for a couple who are carriers of a condition, we are looking for that specific mutation on that embryo. For example, if they know they are in risk for early onset Alzheimer's disease, we could test the embryos for that. But that would require a setup before the IVF cycle starts. That setup is a family-specific mutation analysis, and the PGT lab gets ready before the IVF cycle starts to test for that family-specific mutation. Before we start IVF, we are waiting from the PGT lab to give us a green light. That green light is waiting for a family-specific mutation setup. Then you're going to say, Dr. K, what is that family-specific mutation set up for? And I'm going to tell you the purpose of that. If one of the Youngtimers, they want to know their status, they may or may not want to know their status, but if they want to know their status, they do a blood test, right? In the blood test, or it could be a saliva test, there are thousands of cells, no shortage of cells there. But the structure that I drove you, which is the blastocyst that we are biopsying, it has about 100 plus cells. What we biopsy is only 5 to 8 cells from what makes 100 plus cells. The DNA is limited. And in order to get the information that we want from that small sample, we also need to look at the surrounding markers. Not only at the gene of interest, but the surrounding markers. If the mutation is at the presenilin, we are looking at the family-specific markers for that individual around presenilin.
Just trying to give people a general overview of IVF process with PGT. First, a woman can expect to get her ovaries stimulated to grow eggs. Then those eggs are collected. Then those eggs are combined with sperm in a lab. And then cells from those embryos that are generated are taken and tested at a lab. And then either before or after that, samples are collected from the couple to then build a way to test the embryos, whether there's a mutation in those embryos. Then after that comes the point where then an embryo that's been tested to be negative is then implanted back into the woman, right? And then after a certain amount of time, a pregnancy test is done and then the normal pregnancy continues. I know there's so many factors that can contribute to this, but when a woman starts the fertility medication till when she's, let's say, 4 weeks pregnant, what's a general timeline for a couple to think about when preparing for this process?
It's about 2 months if they want to transfer as soon as possible, 2 to 3 months, because after the embryos are formed, depending on the PGT lab, we could be getting the results in about 3 to 4 weeks. And if they're transferring with the period after, we could look into 2 to 3 months to get into that 4 weeks pregnancy point. But from the moment they walk in for the setup to be prepared, it's going to be maybe 5 to 8 weeks for the setup.
Once you have the eggs and the sperm, how is it that you combine them in the lab? What does fertilization look like in a petri dish?
The eggs are isolated from that tube, and then a couple of hours later, the cells around them are cleaned. After that's followed by the injection of the sperm inside the egg. So basically, embryologists will wash the sperm, and then they will put the sperm into a solution that will make them swim a little slower. That way they could catch them. Then the one that looks good and swims good will be selected and injected inside the egg. The next day, the embryologist will go in under the microscope and see how many of the eggs normally fertilized. This is the fertilization process.
I think it's really important for us to understand how normal inheritance works, going from an egg and a sperm and how those genetic components work together to make the genetic components of an embryo. I'd really like to understand, if a woman has an autosomal dominant mutation, how is it that she has a 50% chance of passing a gene onto her children?
We inherit one allele from each parent to our offspring.
Can you just say at a very basic level what an allele is?
There is a copy of a gene. Each gene is represented with two copies. And there is a copy that's inherited from our mom and another copy that's inherited from our dad. Once we are inheriting that to our offspring or our embryos, we are going to pass on one, not both. And in this case, there is going to be a 50% that woman will have a risk of passing on that mutation to her embryos. The 50% comes from that because we inherit one, because the embryos are supposed to have one copy of each, because they're going to get one copy from our partners. Our male partner is going to be also contributing the other 50% to that embryo's makeup.
When you think about this woman, let's say she carries the mutation. In that sense, you would say that 50% of her eggs probably have the gene that carries the mutation, and the other 50% don't have that gene that causes the mutation, correct?
Statistically, yes. It's not always, the statistics is not always what it turns out. The same for men. This overall for a dominant condition is going to be expected to be 50%.
I've stumbled across so many different abbreviations for this. There's pre-implantation genetic diagnosis, which is PGD. There's pre-implantation genetic testing, PGT. Then there's pre-implantation genetic testing monogenic, or PGT-M. Are these the same thing? Why are there so many different terms?
It's all PGT now under the umbrella, and who in 2017 they released the nomenclature. Under the PGT arm, we are subclassifying them. PGT-A is looking for chromosome numbers. What's a known condition that we're looking for chromosome numbers? Down syndrome. As we are doing the PGT-M, actually, we are looking at the chromosome numbers from the same biopsy. All the patients who are doing PGT-M, we encourage doing PGT-A. At Columbia University, very likely when they come to us, they're going to do these cases with PGT-A, because if you're biopsying, same biopsy could go for the analysis of chromosome numbers as well. But the PGT type that we're talking today is PGT-M, because we're looking for single gene condition. So, and then there is PGT-SR and PGT-HLA. SR is to look for structural rearrangements. Let's say if somebody had a balanced translocation that does not affect their health, but it could impact their offspring. That's looked with PGT-SR. And the audience here probably would not be interested in hearing about that. There's also PGT-HLA when we are looking for a tissue match. For example, the child, one of the siblings has sickle cell disease. We are looking for a bone marrow or stem cell transplant. That's PGT-HLA. And also we are looking for an unaffected child. At the same time, we do it with PGT-M, PGT-HLA. Here we're interested in PGT-A and PGT-M. The previous terms that were used for PGT-A, it was PGS, and for PGT-M, it was PGD. It's just much more clearer to say instead of PGD, because when I say PGD now, I could also mean looking for translocations, chromosome exchanges, not only single gene disorders. This clarifies better. That's why in 2017, they changed the nomenclature for clarification.
Thank you for clarifying that. You talked about when the genetic testing is done, and that's you're growing the embryo to a certain point that then you can take 5 to 8 cells for genetic testing. Can you talk about what happens to those cells and how is testing done? And why is it important that we test embryos instead of eggs or sperm?
Great question. What happens is typically those cells are put in a tube. They have barcodes and they have identifiers. The cell samples, biopsy samples are coming from each embryo. They'll be labeled to the matching embryo. They're kept in conditions, like typically on the fridge until they're shipped. And then after that, they'll be shipped in a couple of days to the PGT lab. Once they're shipped, they're lysed, meaning to get the genetic material out. Then after that, it's going to be, depending on the lab that is sent, it could be an amplification, or it could be directly analysis of the cell sample after the lysis, but it's going to be the laboratory methods to identify mutation and the surrounding markers from that embryo.
My follow-up question is, why can't we just test eggs and sperm before we create an embryo to see if they have a mutation?
The sperm, you wouldn't be able to test for it because it will kill the sperm. Once we take the DNA content of the sperm out, it will kill that sperm. It's no longer going to be able to be used. Sperm testing is not possible before using it. A lot of my patients ask that question too. I don't think it's going to be possible for many years because you just have to use that sperm, right? Also, testing a bunch of sperm doesn't tell us anything about that individual sperm's outcome. Sperm can't be tested before use. Egg, it can be tested before use. It's called polar body biopsy. Here, when you're looking at the egg, once it's retrieved, it's going to have a polar body and some cells surrounding it. This is the results of the first cell division of first meiosis of the egg. This is called a polar body. It's possible to biopsy that polar body, but biopsying it is technically challenging. Also, egg is still going through cell division. As you're biopsying it, you could damage the cell division process. There's a spindle here, and you could damage the egg. It's overall, compared to tropectoderm biopsy, when we grow the embryos to 1 week stage, and when it has that inner cell mass and the tropectoderm, this is the most resilient stage. This is the best stage, is the blast stage to biopsy the embryo. It's still going to be representative to the egg because for monogenic condition, it's going to be representative, but it's not going to be as representative for the PGT-A part. Overall, for aneuploidy, we get better information when it's biopsied at the 1 week stage, and also the embryo is more resilient, and we are going to have better outcomes if we test at the 1 week embryo stage. For people who are thinking that they might be carriers, but they don't have a partner and they are not ready to move forward with embryo freezing, egg freezing is an option for them because they could use those eggs to fertilize with their future partner.
That's such a good point, especially for women who are not yet ready to make a decision about family planning yet.
Certainly.
Is there any risks to the embryo by performing genetic testing or by freezing it? Do we harm the embryo at all during that process?
Great question. And there was a study done, and it was published in our journal, Fertility Sterility. Basically, they biopsied the embryos. So they took embryos, and then the study showed the trophectoderm biopsy, the stage that we are talking about, did not have any impact on the embryo. What they did, to get into the details of the study, they took couples who had 2 embryos suitable for transfer, and the first group was day 3 embryos. The second group was 1-week embryos and blastocysts. They biopsied one blast. They didn't biopsy the other blast. I'm saying blastocyst, shortening as blast. Then they biopsied one day 3 embryo. They did not biopsy the other day 3 embryo, and they transferred both of the embryos. Then they followed the pregnancy, and they did DNA fingerprinting during pregnancy of the woman, detecting the DNA from the embryo. And then once the baby is born, they did buccal swabs, cheek swabs to follow which one created the pregnancy. The day 3 embryos, they had a 40% reduction in pregnancy rate when there was a biopsied embryo. The day 5 embryos, the blast stage embryos, they did not have any change in creating pregnancy, whether the embryo was biopsied or not. That study on its own was already a challenging study to perform because of all the research approvals. Lindsay, you will know the IRB approvals and everything. So it's the best study out there to look. The same group looked at their retrospective data. They compared their biopsied embryos to non-biopsied embryos, all comers, all age groups, and they did not see any change in implantation rates too. Overall, I would say it's the survival of the fittest, in a way that if a woman is young and she has good egg embryo quality, then those embryos will have a less impact. If you're older and if you're having only like poor quality embryos or a few embryos, those embryos may not be doing well with embryology procedures, which comes back to all of these are actually better at a younger age. After the age of 35, there is going to be an increase in chromosomal abnormality, the egg quality. It doesn't happen all of a sudden after the age of 35. It happens gradually, but the sooner we do this better. The 43-year-old woman is trying to do PGT-M. For this, she's going to have less embryos to work with, just because the embryos will be eliminated due to chromosomal abnormality. To summarize your question, no known impact, but the data is from really good studies, but unfortunately those good studies are not too many because of the limited nature of assessment. One thing that I would add is the embryos in this early stage of development is able to renew itself really quickly. If it's biopsied a couple of hours later, you can't tell it's biopsied because all those cells already make up for it, as it renews itself quickly. So in medical terms, we call it pluripotent. That's an advantage.
That sounds like if you just take a few cells out of maybe a day 5 embryo, there's really very little harm to the embryo, and you can't even really detect that cells were taken from that embryo, versus if you take it from a sperm or an egg, you're more likely to cause harm to those cells.
Exactly.
I've heard some couples talk about how they're waiting for a probe to get generated, that you need to have a person's blood drawn, or you need to have a family member's genetic testing report in order to generate a probe. But can you talk about what that process looks like and what a couple can expect during that time?
It all depends on the case. If you already know our status, it's easy. That's disclosure testing. Yes, there's a family-specific setup, but I could even tell you, if you can't find any family member, if you're doing disclosure, if you know your own status, if you can't find a family member, we could test your embryos that are sibling embryos, and they could serve as siblings, and they could be serving as a setup. The setup, the probe preparation could be even after the IVF cycle, if you're doing disclosure. And traditionally, the labs will ask to look for family members, but we could find a way with beautiful, accurate diagnostic accuracy to do a setup after the IVF is done. That's not a problem. The non-disclosure cases, if you don't want to know your own status, now the family members will be needed. Most labs will ask you to have a report or to have at least a family member, and that may not be always an affected family member. It's going to be based on the PGT lab's decision. So our patients will be meeting with the genetic counselor of the PGT lab. In addition to our genetic counselor, we want to get our genetic counselors involved, and the PGT lab's genetic counselor is going to be always involved. And they're going to tell, this is the reports that I need, and this is the family members that we need. Who can we work with? That discussion will be with the PGT lab and the couple. But overall, typically when there is a non-disclosure case, and at least an unaffected family member, preferably an affected family member, but at least an unaffected family member will be asked, and every lab is going to be different on what they're asking and what their comfort level is. And also it could certainly be different for each mutation.
I'm glad you brought up non-disclosure, because I think it's important to say here that if a person is interested in having a baby without the mutation, but doesn't want to know their status, that they can still do this procedure. And you just said it's a little bit more complicating, involving a few more family members maybe than normal, but that it is possible. Is there anything that couples or women should be aware of when they're going through the non-disclosure? Is there any chance that they'll be able to work out that they have it?
These are such great questions, Lindsay. It's certainly something that I discuss every day. And a person who's interested in doing IVF, PGT-M for neurodegenerative disease, and they have the option to get themselves tested. And this is going to be disclosure testing. That's one option we discuss. Other options are going to be non-disclosure testing. But when we are talking about the non-disclosure testing, there is going to be direct and indirect non-disclosure testing. It gets even more complex here. Direct non-disclosure testing, so it involves direct mutation analysis. At this type of testing, direct and also indirect, okay, as both are non-disclosure. The direct non-disclosure means there is a direct mutation analysis. That means the PGT lab knows, but PGT lab, even blinds, typically they're genetic counselors, and the labs that I use for direct non-disclosure, they blind their genetic counselors, and they blind us. I don't know. I encourage my patients to not know egg numbers, no follicle numbers, and no embryo numbers, no numbers at all. Physically, when they have ultrasounds, we turn the ultrasound away from them. And it's something we discussed in the beginning. I do have patients eventually that ask me, what's my number? I want to know. But I specifically tell them, if you're going to ask a number, only ask to me, because the team is instructed not to share the numbers. Majority of my patients will say, doctor, I understand what you're saying. Nobody give me numbers, please. But I have here and there some patients that will say, actually, tell me my numbers. I want to know. And even with that, though, it's impossible for me to know. I'm not blinded to all of these numbers. I get to see all of these numbers, even though I don't share unless asked. Once I get the report, I only see the embryos that are suitable for transfer. I wouldn't be able to tell if that embryo is eliminated because it had a Down syndrome of a chromosomal abnormality, or if that embryo is eliminated because it was really carrier of this condition. But this you'll get to work with more eggs, more embryos, because you're directly testing each and every embryo. Indirect, it certainly requires family members for sure, but in the indirect, it's based on the family members. Let's say, in that patient example that you gave to me, the woman has the early onset Alzheimer risk. Let's say her father was at risk of passing on the condition, right? Everything that comes from the father would be eliminated, and any surrounding marker that comes from the father will be eliminated. Anything that carries her mother, like the grandmother of the embryos, will be included. It's going to be eliminating more embryos. Most patients, they choose direct non-disclosure because they're going to work with more embryos. And not all the labs will do direct non-disclosure. They could do the indirect method more. But overall in my practice, I see more direct non-disclosure from my patients compared to indirect, because our patients want to get more numbers from their embryos. There is always a risk of accidental disclosure. It's always a risk. Somebody in the recovery room could be speaking up louder that you could think of, or somebody may not look at the chart and give the patient the numbers. This accidental disclosure of the numbers is a possibility, but overall, even when that can happen, it really doesn't tell somebody what their status is. Honestly, thinking of all of my patients who did direct non-disclosure, does it come to my mind? Sometimes when I see somebody having so many embryos, and there are a lot of embryos that are looking good, I just want to say, oh, this is great. Maybe they are not carrier of this condition. But it's impossible for me to say that. Actually, I'm not even authorized to give them that information because I don't want to give them the false reassurance. I can't tell either. Nobody could tell. We are blinded at each stage for the part that belongs to us. When I speak with the genetic counselors from the lab, they don't even know how many embryo biopsies that we sent to them. They just know what the report comes, and majority of the communications are just limited to the doctor who's in charge. I hope I could break this complex part into a little bit easier, but non-disclosures, as a summary, please don't focus, because if a patient is interested in coming to us, we're certainly going to discuss those two of the possibilities, including the PGT lab is going to discuss all the possibilities too. Just know that from the people who watch this video, you don't have to know your status. In some cases, you may not need the family members that you were thinking that you needed. It's just every case is different. Always give yourself a chance of having a consultation and exploration.
Yeah, I think that's such an important point. I think a fertility consultation will really help answer some of those really specific questions. The next thing I'd like to ask is, once the genetic tests are received, or maybe not received, let's say we just know that we have a certain, or maybe one embryo that's tested normal, or we just know that we have embryos that tested normal, when do you begin the process of putting that embryo into the female, and what does that cycle look like?
From all of our discussions, that's the easiest part, Lindsay. Now everybody could just really relax and give their brain a break. If they're having regular periods, I will put the embryo 1 week after the ovulation inside the uterus. It's just with a catheter, teeny tiny catheter, you don't even feel it. It's just like having a pap smear. It's just really simple. If they're not getting regular periods, we could give them medications, estrogen and progesterone hormone, to prepare the uterus. And it's about 3 weeks after their period starts, they could have the embryo transferred. It's always a single embryo transfer because the chromosomally tested embryo, our guidelines are to transfer 1 embryo at a time.
What are the typical success rates of IVF to end up with a live birth of a healthy baby?
Once we have a chromosomally balanced embryo, it's about 60% that embryo will create a live birth and creating a pregnancy. If we are talking about a woman in her early 30s who are really looking into starting that process, and if she has good ovarian reserve, we could end up with several embryos. And if it's somebody that is late 30s or early 40s, then it could take a couple of cycles to reach to that point. But it's really depends on that person's ovarian reserve. Sometimes we start the PGT-M cycle thinking that person does not have any issues getting pregnant, never tried pregnancy, just doing this process for PGT-M purposes. We can find some fertility issues along the way. But basically, overall, my experience is if somebody is younger age, we could end up sometimes 4 or 5 embryos from one cycle. Sometimes there are outliers. My last non-disclosure report that I shared with her, it was 10 embryos from one cycle that she had suitable for transfer. That's an outlier. That's a lot of embryos. Not everyone will have that response, but overall, the younger that we think of it, she's 29, like turning 30. And the younger we start the process, the better ovarian reserve we'll have, and the better quality our embryos will be. So it's going to be a better outcome.
On average, like how many cycles, like egg retrievals and implants, can a couple expect to undergo to get pregnant? And is there like an optimal number of embryos that they should have if they want to have a certain number of children in the future?
The second question, I do have an answer. The first, it depends on the person. If they want 2 children, I would say 4 embryos because 60% implantation rate. So it's just always have a backup. And the other is the cases numbers to expect. Overall, I think at the age of 37, 38, there was a publication looking at PGT-M cycles. Actually, in that publication was 3 embryos. Overall, internally, I see more embryos from 3 embryos that are obtained each PGT-M cycle with an average age of 37 from that publication. From our internal data, I see more from my patients. But again, it all depends on the ovarian reserve, age. Over that presentation, there's a video. For time purposes, I didn't play that video, but there's an attrition at each step. It's anticipated once the eggs fertilize, is 30 to 50% will make it to the blast stage only. The rest of the embryos will be arrested, and this for human reproduction is always the case. We see that happening in the human body, just as reflecting as no pregnancy that month. We are selected species, the embryos that divide abnormally, they're not going to be to further stages, but not every egg that is collected will become an embryo. Let's say we got 12 eggs, 10 were mature, 9 fertilized, maybe 3 of them will make it to the blast stage. And if we are looking for a condition that affects 50% of the embryos, it's possible that the person could have just 1 embryo suitable for transfer after also being eliminated for the aneuploidy.
And if you can't disclose how many embryos were, let's say, normal, is there a way for a couple to let their fertility specialist know, we want to have this many kids? Can you have us undergo this amount of cycle, or and the amount of required cycles needed to get this many embryos?
That's a great question. The non-disclosure part ends at the time of the report release. For me, once they do the cycle, the final outcome, I give the results. I'll give the results of the embryos that are suitable for transfer. And if they want to know the sex, I tell them the sex. I tell them about the grading of their embryos. But at the end of the cycle, they know that part because that's important for their family planning. If the first cycle did not reach their goal of that number, they could do the second cycle in that case. It's going to be in the end of each cycle, they're going to know the numbers. Numbers of embryos suitable for transfer, just to clarify.
Yes. Although this can vary by state and by clinic, do you know the typical cost of a single IVF cycle and the added cost of genetic testing, specifically PGT-M?
Absolutely. So it's about 16,000, the embryology procedures, if it's self-pay. In New York State, we have IVF coverage. 3 cycles of IVF will be covered, typically in the state of New York. Most of my patients, that part is covered by insurance, thankfully, and I hope more and more people have it covered. And the setup, the PGT labs will have some specific rates for non-disclosure cases. Testing for PGT-M could take anywhere between $4,000 to $5,000. Sometimes it's closer to $3,000. It just depends. And but for non-disclosure cases, just expect somewhere between $4,000 to $5,000 for the PGT analysis, and that's independent from us. That's just only the lab. And the medications could be taking somewhere between $4,000 to $10,000, the cost of the medications. The average cost of an IVF PGT-M cycle is about $25,000. And the younger we start, the cost is going to be lower because it's going to be less cycles, and also it's going to be less medication.
You did mention that some health insurance does cover these costs, and of course, that's probably dependent on whether your state mandates that IVF is covered. But is there any ways that couples can think about reducing these costs?
Especially when there's an infertility diagnosis involved, they're more likely to cover the state mandate. The challenge here is when there is a non-disclosure case, you don't want to submit your PGT analysis to the insurance. Everything could go to insurance as an IVF cycle. And sometimes there's hidden infertility, sometimes there's male factor when we're looking at it. Finding insurance coverage may not be problematic most of the time for the IVF and the medications. The PGT lab part, I think it's from upfront. Anybody who is doing non-disclosure testing should anticipate to pay that part out of pocket if they're not willing to share this with insurance. Another way to decrease the cost is actually really there should be grants for this. And it's really heartbreaking for me. These technologies are out there and there are people who really want to use it, but it's not accessible to everyone. These are expensive technologies, really expensive technologies. I think organizations for carriers of certain conditions, they should also consider this to support their members who want to pursue this technology.
I did get a question from somebody in our community, because some of our community members live in more rural areas, not in New York City. What would you recommend they do? Do most hospitals and clinics have this technology? Do they need to then go to a specialist? How would they go about finding a specialist that can do this?
I would not do this technology everywhere because it's really important where you go. The embryology lab, it should be good. The ovarian stimulation should be good. And the lab should be the right lab. All of these are really important decisions. This is not a technology for everywhere, unfortunately. Everywhere could say, yes, we could do it, but just so many sensitive steps that are involved. You could reach out to me. Anybody who wants to reach out, they could go to our website at Columbia University Fertility Center. If you Google pre-pregnancy genetics Columbia, or you'll find our website. You could even self-refer, but certainly it should be somewhere that has experience on this. Looking for places that would have more experience on this is going to be important.
Yes. Talking about how doing things at a younger age is important. Is there a right time or age to pursue IVF with PGT-M?
The sooner they know that they want to do IVF PGT-M for this, do it, because you don't have to transfer your embryos. My patient that I shared the reports, she just had her Mirena IUD placed after the egg retrieval cycle. It's just really, you don't have to transfer the embryos. It's important to do it sooner than later. I don't want to give an age cutoff because we only look at the future. If anybody watching is above that age cutoff, it will discourage them. And they could be doing great. I sometimes see 42-year-olds who have much more than anticipated number of embryos too, but they're outliers. The sooner is the better.
Are there some physical and emotional burdens that come with IVF and genetic testing that individuals and couples should know about and prepare themselves for before pursuing this procedure?
It is emotionally challenging, and especially for people who did not have trouble getting pregnant. But I see a lot of PGT-M patients because of the pre-pregnancy genetics program. I have patients, for example, who come from natural pregnancies and they had to terminate the pregnancy because they found that they're passing on a certain genetic condition. It's just really heartbreaking sometimes. If there's not an embryo suitable for transfer, or if there's a pregnancy loss, it's just really emotionally challenging. Overall, if the results are good, I think it's just like overall a happy process. Overall, the cases that I have observed, that I've seen managed, they had good outcomes. And sometimes I have once in a while patients with lower ovarian reserve that I have to do a couple of cycles, but that's really not. I had a patient, for example, who had premature ovarian insufficiency and the husband was at risk for neurodegenerative disease. She had to do a couple of those cycles. Every time it's just 1 to 2 eggs, 1 to 2 eggs. They all made embryos, but now she's pregnant. It was every time when there was just a low number of eggs, just you're holding our breath. They will be fertilizing. Will they make it to blast? Will they? She was the person who wanted to know all the numbers, and actually knowing her numbers, nobody could tell what the status is because the numbers are low. But it's an emotional challenge for sure. About the IVF pregnancies versus natural pregnancies, once we transfer one embryo at a time, their outcomes are comparable to natural pregnancies. That's what the data shows. Overall, it's important to do single embryo transfer. Based on historic data, the obstetricians will do a cardiac echo on the baby, but overall, majority of the IVF pregnancies will be healthy children. It's overall a safe process with more than 40 years of data behind it. And the embryo biopsy and the freezing of the embryos, there are a lot of data accumulating from that too. There is a slightly higher risk of hypertension of pregnancy, preeclampsia, when there are frozen embryo transfers, and especially with the medicated transfer technique, the preeclampsia risk is increased. Overall, it's a slight statistical increase. Majority of the babies as a result of IVF are healthy, perfect.
You talked a little bit about the emotional journey of IVF, and I want to say for anybody out there who is thinking about going through this or is going through it and needs some support, we do have members of our community who have gone through it and would be more than happy to connect with you. I think it's important to also reach out to fertility support groups and other people who are going through this process because it can feel isolating. When you have that support, I think it makes it that much easier. Are there any physical risks to IVF that women should be aware of before they begin?
The risks, I think we talked along the process. With the current techniques and the freezing is going to be less than 1 in 100, severe hyperstimulation. And the bleeding and infection, yeah, there will be some bleeding and we don't see much infection, but that's the degree that would require hospitalization or IV antibiotics is uncommon. Certainly these are risks, but also when the ovaries get big, they could twist, which is called ovarian torsion. Our patients are careful, but if somebody is not careful and if they're doing burpees as they're going through the process, the ovaries could twist. These are the things to know overall. Then see one question that you did not ask during the process, and before we finish, I would like to add, it's completely not related, But people who do this are going to test their embryos, and it's very obvious, but only we're testing the embryos for that condition. We are testing for the pre-implantation mutation. It's going to be exactly that mutation that you are inheriting, or you have the risk of inheriting from your parents, is what we are testing for. For anybody who's in this audience, if there is a new mutation in the pre-implantation gene, it's not going to be showing up on this testing. Chances of that happening is going to be extremely rare. But if there's a new mutation in another gene, it's not going to show up. But still only testing for that specific mutation of which we are at risk of inheriting.
Thank you for clarifying that. I think that sums it up. I just want to express my extreme gratitude for you, Dr. K, joining us, giving your time and expertise to this topic, which I think a lot of our community members are interested in learning about, and the potential and the power of stopping this disease after one generation is something that I think is important to think about, because it's complicated to just make sure we understand more about it so that we can, again, make informed decisions. Thank you for taking the time to help us understand and make those informed decisions. I really appreciate it.
Oh, Lindsay, it's my pleasure. It's all the great work from you. And I'm always happy here to give the option to do PGT, or even at Columbia at pre-pregnancy genetics program, discuss other reproductive options to anybody who's interested. If anybody is willing to reach out to me, they could go to the pre-pregnancy genetics program website and fill in that information. And it's been great.